everybody. Good afternoon and happy Monday. So good to see everyone. Give everybody a second to get connected. So good to see everyone. We have a very interesting topic today. So I'm going to go ahead and get started and introduce myself. I'm Anissa Mitchell with PMD Alliance, and I want to welcome you to our Lunch with Docs today. We're going to have Dr. Sultan Mari joining us, and we're going to be discussing disease-modifying treatments and research. In the meantime, before we get him started, I just want to remind you that we are going to keep you muted during the presentation, but we do encourage you to open up your chat box at the bottom of your screen and send us your questions, and we will ask those at the end. Also, you will see that at the bottom, there's a looks like closed captioning, which is a fairly new feature that is offered. You can turn that off if you don't like that. So if you scroll at the bottom, you'll see where it says live transcription. And if you click that, you can do the hide the subtitles. And if you like that, you can leave it. So I'm going to introduce Dr. Mari. He's with the Cleveland Clinic in Las Vegas, and he is the lead of the Parkinson's and movement disorders program there. He's a renowned expert in Parkinson's and other movement disorders research, and he's going to be talking to us today about disease-modifying trials in Parkinson's disease. We currently don't have any therapy that can specifically slow down or stop the progression of Parkinson's, but there's a lot of interest in disease-modifying treatments. So he's going to be sharing some of those insights into the research, why we've had some challenges with it, and why this research is so important for our treatment. So Dr. Mari, thank you for joining us. I know he had to pop out and pop back in. It looks like he's already started sharing his screen. I'm going to hand that over to you, Dr. Mari. And I don't know if he's still muted. Give us 1 second.
Can you hear me now?
There you are. Yes, we can hear you now.
Thank you, Anissa, and thank you for the invitation by the PMD Alliance. It is my pleasure to speak to you again. I am always delighted to cover some of these interesting topics in Parkinson's disease for your group, and I was particularly excited to address the disease-modifying therapies, as that is certainly on the mind of all of us, patients, providers, academicians, everyone, as one of the most important unmet needs and knowledge gaps, where hopefully we are getting close to some breakthrough after decades of disappointment and lack of translation of preclinical, what looked like breakthrough and successful research results into any human clinical trials. Before I go on, you guys see the slides? Are they working now? Because earlier I was trying to test it and share, but then it got stuck. So I'm glad it's working. So as Anissa mentioned, I am the Ruvo Family Chair and Director of the Parkinson and Movement Disorder Program at the Cleveland Clinic Ruvo Center for Brain Health. I am also a professor of neurology at UNLV, the University of Nevada in Las Vegas, and I also kept my adjunct professorship at Johns Hopkins, where I previously worked before I joined the Cleveland Clinic 4 years ago. So I have some disclosures. I'm not going to spend much time on those. I have worked as an advisor. I received grants from anyone who's willing to give grants, but those are institutional grants for research support. And I also did some limited speaking, although not for about 1.5 years now. So I would like to cover a number of areas of interest relating to disease-modifying trials. By the way, I think it is important to address the definitions first and discuss how we mention sometimes neuroprotective and what that buzzword is meant to describe relative to disease modifying. These are oftentimes used as synonyms, and whether or not that's correct, we'll just briefly touch upon. I'm not going to spend a whole lot of on pathology versus etiology. Enough to mention that once we are trying to develop strategies for appropriate and finally successful disease-modifying interventions, we really need to focus on etiology and less so on pathology, and even less so on clinical definitions and clinical diagnostic criteria, because those don't determine the causes. Etiology relates to the causes. Etiology describes what is it that starts a pathological process that eventually leads to pathology. So pathology is a consequence of something that starts something that's other than normal, and that's something that starts it. The nature, the description, and understanding of that step is critical in our abilities to stop it. Of course, once the whole cascade of events at the molecular level and then at the brain tissue level and beyond begins, it's not all lost. It is still an area where we can develop targets to slow that process or intervene in some ways. But it is primarily prevention that is going to produce the greatest impact. I would like to spend a little time on addressing our current understanding as to what went wrong. Why is it that we are sitting here in 2021 without any results to show for it, without any successful clinical intervention that can slow down, prevent the progression of Parkinson's disease, despite all the trying? There was no lack of trying, and certainly in terms of years, effort, and money, a lot has been invested in trying to tackle this problem, which is sometimes referred to as the holy grail of Parkinson research. Now, one issue out of those is the animal modeling issue. As you will see on the slide that I described, the potential contributors and reasons for the failure, the animal modeling is one of the many. I think it's an important one, so I will spend a little more time on how we should get this right and how the appropriate and accurate animal modeling that speaks to that etiology, speaks to what it is exactly that goes wrong, and then leads to the cascade of events which will then be responsible for Parkinson's disease itself. And then after that, I will go through the number of clinical trials that are currently targeting disease modifying therapies and some of the main classes of them. Fortunately, we don't have any shortage of these. We have at least 6 or 7 different targets that are being currently evaluated, and I would say rather promising. And among those 6 or 7 different targets, there are almost 5 dozen clinical trials ongoing in the world right now, which are at least phase 2 or beyond, phase 2, phase 2B, or phase 3 trials, multi-site, double-blind, controlled trials that are trying to exploit one of these targets. And some of them are further along in their recruitment than others. Of course, the pandemic slowed down or in some cases halted the clinical trial efforts in many parts of the world, including the United States. So that was a little bit of a setback. But as we are limping out of this pandemic and turning the corner on it, clinical trial operations are resuming. And again, there is no shortage of trying. There are many, many clinical trials ongoing. Some of them are closer to completion than others. And I would say that almost all of them are far better clinical trials with far better thought process than any one in the preceding 2 to 3 decades. Having said that, I still believe there are things to do to make it better. And I think besides the proper animal modeling, if I can say something right here at the beginning slide, one area that we will have to really deal with very seriously is the clinical trial recruitment and patient selection. For many years, actually 2, 3 decades, the general recruitment idea behind disease modifying clinical trials was the same as for symptomatic trials. And in the next slide, I will explain what symptomatic is versus what disease modifying is and how fundamentally we are looking at completely different worlds when we are trying to make the symptoms better and improve how you look, how you function, versus when we try to alter the course of the disease itself so that it's not going to go downhill as much or as fast. So those are very different concepts, and I will try to explain during this talk that the recruitment, which we have done for every Parkinson's disease clinical trials in the past, anchored on the clinical diagnosis, is a mistake when it comes to disease modifying trials because how you look may not actually explain or have anything to do, for that matter, as to how the disease started, what was the original cause. You could look the similar way from two completely different pathological processes, and that just itself would tell you that how you would want to stop the pathological process cannot be the same, even though the patient can look the same, the symptoms could look the same. So, tying the clinical trial recruitment on the clinical diagnosis is one other mistake that we have been making all this time. So again, just to make sure that we get a clear understanding between symptomatic and disease modifying, I have a full slide on just that. And to give you a personal example to demonstrate how patients have a hard time understanding what disease modifying even is, um, I have been running disease modifying clinical trials for decades. That's my primary research interest, and I've been in a movement disorder specialist for a long time. When we randomize patients between the active intervention versus placebo, almost always I have a few patients who will tell me, well, doc, you know what? I think I'm in the placebo arm. And then I'm like, okay, well, why do you say that? What makes you think that? And their answer is, well, I don't think I'm better. And so that approach or that belief is what tells you that people who are in these trials expect to get better from a disease modifying intervention. Well, you will never get better from a disease. It's the symptom that makes you bad. You could be slow, stiff. You could have tremor, balance problems, all of the other non-motor issues. There's no shortage of sources of disability from the symptoms of Parkinson's disease. When we use symptomatic interventions, which are all the currently available treatments for Parkinson's disease, the purpose is to relieve the impact of those symptoms, make the tremor less, make the stiffness a little bit better so that you feel better and you function better. A disease modifying therapy, on the other hand, which again, we don't have, as Anissa mentioned in the introduction, there is no currently proven or approved disease modifying therapy, intervention, drug, anything. Um, when we do, and if you were to go on such a treatment, you would not get better those symptoms that you're experiencing now, the tremor, the stiffness, the balance problems, or the non-motor issues, they will be the same. It is not to relieve the symptoms. What would be different if it was working, and that's what we are trying to get to, but we haven't so far. But if we did have an effective and working disease modifying treatment, what you would experience is that you would not go downhill in the future as rapidly. In other words, if you lose, like for instance, one anchor as to reflect on the severity of your Parkinsonism is the so-called Unified Parkinson Disease Rating Scale. The Unified Parkinson Disease Rating Scale is a standard, or UPDRS, is a standard motor exam that um, certified examiner, usually a movement disorder neurologist, will do with you finger taps, hand grips, alternating movements, and a whole slew of other items, a total of 31 exam items. And then they rate it between zero being the absolutely normal, no sign, no symptom, to four, which is the absolute worst possible finding on each of these 31 items. So once you add that up, you get a total motor score. So let's say you progress, because Parkinson's disease is progressive, on average 4 points on that scale per year. So in 10 years, you will be 40 points worse if you go like that. I mean, it's not exactly like that. Everybody's different. It's not perfectly linear. But just for the case, just the sake of simplicity, let's say in 10 years, you get worse on that particular scale by 10 points. Now, if you had a disease modifying treatment that was 50% effective, then 10 years, you wouldn't be 40 points worse, you would be 20 points worse. And then, if you had a perfect disease modifying treatment that not only slows, but completely halts, completely stops the progression of Parkinson's disease, then technically 10 years later, you would not be worse by a single point either, although some people would make a case that just aging can add a point over that period of time or two. But the bottom line is that you would not immediately see any improvement. You would not get points and points on that scale better than before treatment, but you would not get worse than that baseline over time in the future. So, in other words, at an individual level, unfortunately, there is no way to tell if it's working, because you would not be any different at the moment when you started. It would be apparent years and years later by not losing as much ground. And I would like to add, because I use the motor exam as the primary anchor point to demonstrate as to how it would work if it did work. Um, Now, the good news about disease modifying treatments, even though they have been elusive so far, but once we do have them, they don't only protect you from worsening motor symptoms, but they would also help with non-motor symptoms, which none of the currently um, dopamine-based symptomatic treatments are capable of doing mostly. So, in other words, cognitive impairment, other neuropsychiatric features, dysautonomia, gastrointestinal, and urological problems, blood pressure regulation issues, there's a whole slew of so-called non-motor problems that are largely not related to the dopamine system, and levodopa or other dopamine-based symptomatic treatments usually are not very effective for those non-motor symptoms, but those non-motor symptoms are also related to the neurodegeneration, to the process in the brain and elsewhere in the autonomic and enteric nervous system, where neurons and glial cells and nerve fibers die and degenerate over time. That's why we have these symptoms eventually. Now, out of those different neurons, the dopamine neurons are particularly important because they are responsible in the nigrostriatal system for most of the cardinal motor features through which Parkinson's disease is recognized in the first place, the ones that I mentioned: tremor, stiffness, slowness, and balance problems. Now, when you protect or treat anything related to the dopamine system, you are focusing on those motor symptoms. But if you had a neuroprotective or so-called disease modifying intervention, that would help neurons across the board, not only the dopamine neurons, but the norepinephrine neurons, the serotonergic neurons, acetylcholine neurons, glutamatergic, all the other types of neurons that are blamed for some of these non-motor symptoms. By the way, the non-motor symptoms can be very disabling as well. In fact, in more advanced cases of Parkinson's disease, oftentimes it is the non-motor symptoms that are the primary source of disability. So, in other words, with the disease modifying approach, we could help not only the motor symptoms and the dopaminergic cells, but every cell and every symptom, and prevent the progression from ongoing, or at least slowing it. That's the hope. Now, to the question as to what is the difference between neuroprotective and disease modifying, because these words are oftentimes used as synonyms in common lingo, and they are not exactly synonyms. So, the disease modifying is a term that is clinically defined. It is defined by your apparent clinical progression over time, how bad you are 2 years from now, 5 years from now, 10, 15 years from now. We don't count neurons in the brain. We don't have the ability to do so, but we can look at certain clinical features that we rely on to determine the severity of your Parkinsonism. So that is disease modifying if we can do something that helps us prevent the progression or slow it. And that is disease modifying is a term that is defined based on such clinical concept. Neuroprotective is a stronger term. It actually means that we did something that de facto protected neurons themselves. Now, the difference is that when we do these trials, we hope that that's what happens. That's how we exert a disease modifying effect, by protecting the neurons. But we don't actually know that by looking at a person clinically. To know that for sure, you have to look at the microscope and look at the neuron. And so the preclinical studies that are testing these various interventions and neuroprotective agents can truly use neuroprotective, because they can actually count the neurons in the Petri dish. So I'm going to skip the next historical perspective largely, basically just to say that we have mastered the clinical trial design trade very well. It came with levodopa, and by the way, that wasn't even a very sophisticated clinical trial, but we got very good in designing clinical trials where we can minimize the cost, minimize the number of people enrolled, minimize the duration of the trial for still detecting a statistically significant difference. So all that know-how, all that knowledge of clinical trial design mastery came from those symptomatic trials when we were trying dopamine agonists, adjuvants, all the different treatments that are maybe 30 different Parkinson treatments available symptomatically FDA approved at the moment. All of them came from these highly sophisticated, high-end clinical trials that we have learned how to do over the decades. The problem is that knowledge, that mastery, applies very little to actually doing disease modifying trials, because it's a different animal, because we're looking at different questions, and just as I mentioned earlier, starting with how we select patients, it's not the same. If we enroll every patient who has Parkinson's disease who meets the clinical diagnostic criteria for Parkinson's disease, they could be a very heterogeneous group as to how their Parkinson's disease began. What was the molecular initial step? And as I mentioned earlier, the etiology. We know that there are genetic forms of Parkinson's, and the targets, the way to stop that process must be different from one person to another, depending on their individual specific select causes of their Parkinson's disease. So if we just enroll everyone who has the clinical diagnosis of Parkinson's disease, we end up with a heterogeneous group with regards to that etiology, the initial starting step, and our targets, which would be successful and helpful finally finding a disease modifying trial, will have to relate to those specific targets. That's not the same in everybody who meets the clinical diagnostic criteria for Parkinson's disease. And so that's part of the reason why we have this not too uh, glamorous and favorable track record of translation. Anything and everything that has ever been tried in the past almost 30 years in disease modifying trials came from very promising preclinical work. These were celebrated in news media articles, TV reports of major breakthroughs. Any one of these compounds that you see here on the right, or the left for that matter, were very, very promising at some point before they were put into humans. Now, I must say that it's not an easy task because there are no Parkinson patient animals out there. There are no natural occurrence of Parkinson's disease in any known animal. So when we use these various preclinical triaging and screening and other basic science operations to find compounds that can protect neurons, we have to make some assumptions. We can have to find some workarounds and tissue from Parkinsonian brains or cultures and tissues and other types of things. And then finally, animal modeling. But none of them is perfect. None of them will give you exactly what's happening in an actual human Parkinsonian brain in vivo. And so that limitation is making it very hard. And so these various experimental compounds that were previously developed and tested looked all fantastic in the basic science laboratory, in the preclinical stages. And then, of course, there was a lot of money and effort put into the translation, bringing them from the preclinical basic science prep lab to the clinical trial domain. And then when that happened is what you see on the slide here. We are hitting absolutely zero. None of them have been successful so far. So just briefly, this list can be made longer, but just briefly the main potential causes of those failures. And of course, failure is never a good thing. You always want to be successful, but the best use of failures is to learn from them. And that's what we are trying to do. We are trying to analyze what may have been the primary contributors of these failures. And one thing, the number one on this bullet list is that what we have learned in our many decades of successfully running symptomatic clinical trials, guess what? It's not really applicable to disease modifying trials, and first and foremost, patient selection. And I know that it's for many investigators, it's difficult to say, I'm not going to enroll everyone. I will only look for this particular genetic mutation carrier, or this particular molecular signature or neuroimaging finding. And even though I have 100 patients that are trying to get into this trial and I have to triage them, out of those 100, it's only two that actually meet the criteria for this molecular screening that will identify the 2 patients out of 100 where my compound, which I hope is going to slow down the progression, will target and engage a target that's relevant to the molecular signature of those 2 patients, but not the other 98. Because what happens if you enroll all the 100 and on the basis that they meet the clinical diagnostic criteria for Parkinson's disease, and there are 2 such criteria. The more widespread used is the so-called UK Brain Bank clinical diagnostic criteria. That's what most movement disorder specialists use in the clinical practice. And there is a more recent and somewhat more complicated one. It's called MDS, Clinical Diagnostic Criteria, Movement Disorder Society. Clinical trials split as to which one they require, but still, those 100 patients will meet either of those clinical diagnostic criteria sets. You enroll them, and your miracle treatment, this disease modifying new compound, will stop the progression in 2 of those, but not the other 98. You analyze the data in the aggregate format and the averages, and you find that there is no effect. Trial failed. Let's move on, test the other one. Let's blow another $50 million on the next clinical trial because this just didn't work. Well, you might have missed it because of the inclusion of the 98 that didn't have a relevant target to your intervention. And if you screened and identified that too, it would have been very hard for your site to meet your enrollment minimum, but then maybe other sites could help. And so the approach needs to be changed in that regard. I also touched upon the animal models. And so, again, as I mentioned earlier, we are not lucky in the sense that naturally Parkinson's disease is not occurring in any known animal. So we can't just use a perfect animal model because there isn't one. And there was a tremendous enthusiasm in the late 70s and early 80s when the MPTP story was discovered. MPTP is a contaminant of street synthetic narcotic drugs used to be used in California. Bill Langston figured this out. What happened was some young individuals who were intravenous drug abusers showed up in emergency rooms in large Californian cities, especially in the Bay Area, who were end-stage Parkinsonian. And the emergency room physicians were perplexed because they thought this is an end-stage patient who must have had Parkinson's disease for decades, whereas they revealed that they were perfectly fine just the day before. And then they identified this very powerful poison that contaminated their homemade opioid type narcotics, which is called MPTP, that can turn anyone into end-stage Parkinsonian within hours. Because it selectively targets the dopamine neurons and wipes them out instantly. So when this was discovered, MPTP was celebrated as the ultimate savior for Parkinson's disease because they could now create animal models by injecting MPTP to various animals or just one side of the brain. In my early career, I was working with these various MPTP animals, including monkeys, where we injected MPTP to one carotid, and that made the monkey Parkinsonian on one side of the body, but not the other. So the one side could be a control for the other. Now, these MPTP and other toxin-based animal models were perfect for finding symptomatic treatments because you knocked out the dopamine network entirely, and then you could test dopaminergic drugs as to how well they worked. But these same toxin-based animal models were misleading and in the end useless when we are trying to find something that stops the causing factors or the etiology, the initial cause of Parkinson's disease. Because the knocking out artificially with a powerful toxin those dopamine neurons has nothing to do with how Parkinson's disease naturally develops in anybody, let alone in most people. There are some environmental factors, don't get me wrong, that there's the research into those is important, but the animal models that are created by just knocking out the dopaminergic system chemically is certainly not the way that represents or models how Parkinson's disease develops in a human in a natural way. Now, we have improved from there, and toxin based animal models are increasingly sidelined and replaced by better animal models. And I'd like to single out two of those. One is called PFF, animal modeling. It's mostly in rodents, primarily mice, where a protein fragment of the alpha synuclein, the abnormally conformed alpha synuclein, is injected into the striatum, into the deep brain of the mice. Alpha synuclein is a protein central to Parkinson's disease pathology. We know that. We know that from human pathological and pathophysiological research studies. So what happens in a normal in humans is that the normal alpha synuclein will change its conformation and thereby become toxic. Everyone, with or without Parkinson's disease, every human has alpha synuclein protein in their brain. That's normal. But what happens to it in Parkinson's disease is that it changes its conformation. It becomes water insoluble. It forms aggregates or clumps within the cells and eventually becomes toxic. Now, there is no difference between the healthy physiological form of alpha synuclein and the bad toxic conformation changed form of alpha synuclein in the peptide sequence. So it's the same protein chemically, but in space, they can assume two different conformations. And the one that the bad toxic alpha synuclein takes is not going to go back to the physiology. Once it finds that conformation, it will not only stay that way, but it will make other alpha synuclein molecules around it in its vicinity also take up this conformation change. And that spreads and propagates throughout the entire brain, and not only the brain, but also in the peripheral nervous system, the enteric nervous system, the autonomic nervous system. So what it is that they isolated this bad alpha synuclein, took a piece of the part that is responsible for the bad conformation, and injected that into the mice brain. And what it does there, because the mice also has alpha synuclein, that's conservative across a large part of our evolution. So what happens is that the healthy, normal mice and their healthy normal alpha synuclein will start also sort of taking up this conformation change toxic alpha synuclein, and that propagates through their brain. So over time they will develop a Parkinsonian type state, which can be evidenced by pathology. They have Lewy bodies like the human brain, Parkinsonian brain has, and they will have behavioral changes such as slowness that also resembles the human condition. Similarly, there is a transgenic animal model whereby a particular human mutation, which is a very rare mutation, the conformation change I described earlier from the healthy alpha synuclein to the bad one happens under a number of different circumstances, some genetic influences, some environment influences. That is the whole kind of target of the research into the etiology of Parkinson's disease. But there is one rare cause of that where somebody has a mutation in the gene that transcribes alpha synuclein. And if you have that mutation, almost certainly you will have Parkinson's disease because your alpha synuclein will not be stable. It will just a question of time. It will go into the toxic form. So they took that mutant gene out of the human patients who had that, put that into a vector and into the mice. So these mice have the human version of mutated alpha-synuclein gene, and they will necessarily develop a Parkinsonian condition because they will develop that pathology. These two animal models, the PFF and the human mutated alpha-synuclein transgenic mice, are relatively recent, and that is part of the reason why we are more optimistic today in finding disease-modifying trials, because our animal models are better. These animal models are night and day better, light years better than the old MPTP and other toxin-based animal models, which the toxin-based animal models, as I mentioned earlier, don't tell us much about the human condition and how that starts. They are not modeling the disease inception and etiology well at all, because that's not how you don't drink MPTP to get Parkinson's disease. That's not how it happens in the natural human population. So what can we learn from those animal models? Not much, not about how to stop the progression or prevent Parkinson's disease. The next thing on the list is the third one, the timing issue, which is the notion of the horses are out of the barn. When we are studying these animal models and other ways of how to stop or prevent the underlying pathology, we have the control of timing. We can have a preventative agent or intervention and apply it at our time of choosing, early, late, before the injury, after the injury, at the same time of the exposure to the injury, or we can do anything as early as we want. In real life, with actual patients, we don't have that luxury. We don't have that ability to time it. We see patients who already have Parkinson's disease, and the process that led to their Parkinson's disease started years and years, if not decades, prior to the first symptoms. So, unfortunately, when we see patients, even when the first symptoms are presented, de novo, freshly diagnosed, it is already far ahead in the game. And according to some estimates, up to 80% of those nigrostriatal dopaminergic neurons have already been lost at the time you have your first symptom. So we don't have the power of wheeling time back and go back in time 5 years, 10 years more and apply some preventative intervention once you already have Parkinson's disease. And of course, in these disease modifying trials, we have to enroll Parkinson patients who already have Parkinson's disease. We don't know how to roll back time. On that note, we are fixing that to some extent as well, whereas we don't have the power to time travel. We do have some ability to predict what's going to happen in the future. And those are the so-called prodromal conditions, which have a lot of interest lately in the Parkinson research world, because these prodromal conditions are patients who have a condition which is not Parkinson's disease yet, but their risk of developing Parkinson's disease is increased. One of those is the RBD or REM behavior disorder. Another one is the anosmia or loss of sense of smell. And I mentioned genes. There are many different genetic mutations which are known as risk genes, making the potential of developing Parkinson's disease later in life much higher than the general population. So these so-called prodromal conditions are heavily sought after by many researchers because they are perfect for trying these preventative and disease modifying interventions and see if their conversion to Parkinson's disease may reduce, or if they do develop Parkinson's disease, whether the rate of progression will be less than their counterparts or the control. So that's the timing issue. The fourth on the list is the lack of specific markers. I mentioned earlier that to this date, our primary outcome measure in determining progression in Parkinson's disease is the UPDRS. I mentioned the Unified Parkinson's Disease Rating Scale. We ask patients to do various motor tasks, and that we score, which is entirely subjective. I score it one way, the next guy will score it slightly differently. And not only that, it is suffering from intra-rater as well as inter-rater reliability issues. It is also very variable. If you are more motivated, you will be faster. If you sleep better, you will be faster. If you won the lottery, you will be euphoric and then you will do faster. If you don't sleep, you will be slower. You have the flu, you will be slower. And those symptomatic medications that I mentioned earlier make a night and day difference in these scores. If you are in the best point in your medication cycle, your score could be 100% better than when you're in the worst point, maybe just a couple of hours apart. And of course, we don't have a perfect way to control for that. So that's why this score is all over the map and very noisy. And that's why we need long trials with many participants to find a statistical significant difference of change of that UPDR score. If I could look at the number of brain cells and I had a number and I see how many we saved over time, that would be wonderful. We wouldn't need to have these long trials with thousands of individuals. It could be a lot more efficient. Well, we don't have that ability, but we are working on developing better markers of progression. And that's a very critical issue. I already touched on the heterogeneity with the 100 patients, two being of a particular kind or having a molecular marker. This heterogeneity is a major flaw of earlier disease modifying trials because they just assume that everybody is the same. They just assume that everybody is the clone of each other and there is no difference with regards to targeting, molecular types, genetics, and just if they meet the clinical diagnostic criteria, that's good enough. Let's enroll them. But that puts together a heterogeneous group when it comes to the etiology, when it comes to how to target the slowing of the progression. And because of that heterogeneity, the results were washed out. As I said in the previous example, if you had two that you stop the progression, the other 98 in the group will wash it out. You will never see the result. And that heterogeneity was one of the reasons for those failures. Of course, we can always know more about what really is going on in Parkinson's disease, what is causing Parkinson's disease. That knowledge is growing by leaps and bounds. So I think we are making some significant progress there. And that's why we have those 5 or 6 targets now that I mentioned earlier that are being currently tested and exploited for the currently ongoing disease modifying clinical trials. So there is hope, there is light at the end of the tunnel. So again, the last point here is that if there was just one single cause that caused Parkinson's disease, we would have figured it out by now. Part of the complexity that not only that patients are heterogeneous with regards to the contributors and causes of their Parkinson's disease, but it's also that in any individual, there isn't just one cause. There isn't just one factor. It's a constellation of several. I mentioned the genes. I mentioned how having certain mutations will increase your susceptibility to developing Parkinson's. And those are the risk genes. There are many genes. There could be a combination of 100 that will have some impact on your Parkinson risk. And then, of course, the environment. You are exposed to well water, pesticides, some of due to the Agent Orange. So when I was dismissing toxins as a basis for animal modeling for disease-modifying trials, I also must acknowledge that toxins are very important in how Parkinson's disease develops in individuals. Not a single toxin, and not in a single way and not in everybody, but to some extent. And of course, a lot of people are exposed to the same materials and never have Parkinson's disease. But that's exactly why it is important to understand the genetics and the genetic susceptibility of these. So, because the multiple different factors and contributors combining in any one individual, it makes this whole thing harder. And then, of course, in the animal modeling or any other preclinical testing that we can do, we cannot really model that multifactorial nature of true Parkinson's disease in actual humans too well. Anyway, I mentioned that in my early work, I have been involved with. Looks like my slides are not updating. Let me. Okay. Um, this is a book chapter I wrote in 1996, published in 1997, where even 24 years ago, I already almost a quarter century ago, I warned against the MPTP modeling as being a good tool for disease modifying trials. And at that time, there was a lot of headwind with that idea, but now it's more widespread and more universally acknowledged that we were in a pretty much a dead end with those MPTP animals. I wanted to mention this one paper because I saw you that graveyard with all the failed clinical trials when it came to disease modifying treatment translation from preclinical to clinical. There is one that is still the only one and somewhat controversial, a single site phase 2b study using exenatide, which is a GLP-1 analog already used as a diabetes treatment, produced a very minimally significant slowing of the rate of progression in a group of about 60 patients over a year or so. So maybe there is, some light at the end of the tunnel. A lot of people don't accept that as meaningful, but we are doing as best as we can. Some of those already identified contributors that are relevant to the pathogenesis of Parkinson's disease. And these are some of the processes at the cellular level and the molecular level that are being targeted for disease modifying. And as we are running out of time, I just wanted to mention that there are many genes that we understand their molecular contribution. I didn't have a chance to talk about the prion hypothesis, but I explained that the bad synuclein propagates and makes the good synuclein bad, and that's similar to the way that prions spread, with one important difference, which is that the prion diseases such as mad cow disease and others, Creutzfeldt variant Creutzfeldt-Jakob disease, they jump from one individual to another, whereas proteinopathies, as we call synucleinopathies, and the synuclein pathology does not propagate from one person to another. To our knowledge, it does propagate within the brain. Anyway, as we close out now, I just wanted to show you a table that shows some of these different targets. I mentioned GLP-1, that's a glucagon-like peptide 1 receptor analogs. Maybe this is the most promising in my opinion, but I'm biased because I'm one of the co-founders of Neurali. This is like exenatide that I showed you on that paper, except it's a pegylated form, and it seems to be even better. But there are many others, and this is not even a full list. c-Abl inhibitors, again, a molecular phosphorylase target, gained a lot of popularity with the nilotinib, and now they moved on with other compounds that sound better. There are many anti-inflammatory and mitochondrial enhancing targets, immune therapies, gene therapies and trophic factors are also being exploited, lots of immune therapies. So there's a lot of these trials, as I mentioned, altogether almost 6 of them that are currently ongoing. And if you have a chance, try to learn more about them. I think this is the really the key to the future, where we will be able to slow the progression of the disease, but even prevent the disease if we approach those prodromal cases that I mentioned earlier. So that's I know that I skipped a few slides, but I think we touched upon the most important key points relating to the state of the art when it comes to disease modifying trials.
This has been really interesting and obviously a very, very complex process. We do have a couple of questions. We have a couple minutes. So one person wanted to know what you could say about siblings who one had early onset and the other was a typical onset. What have you seen maybe in your research?
Are they fraternal or maternal twins?
Didn't say they're
Are
twins,
they
they're just siblings.
siblings? Sorry.
Siblings.
So that's fraternal by definition. So with different genetic mixes, it is perfectly possible that the individual who had the later onset was a different type. It could be just a what we call a sporadic, whereas the early onset could have been carrying one of those mutations. Pink one, for instance, is a one mutation that is recessive, and so certainly that could be the case that the person who had the regular sort of sporadic case did not have the two copies of the pink one. It would be a lot of possibilities. It is also possible there are certain genetic influences or so-called risk genes where you can have a quite different picture, so that not everyone who carry that particular mutation will look alike. So there is some phenotypical, we call it phenocopies, where you have the same mutation and you don't look the same. There are other factors that could factor in, and we are understanding more and more of multigenic influences where you may have one particular risk gene, but then you have a constellation of others, and that can influence the clinical picture. So there's a lot of possibilities there.
Okay, and another person wanted to know in regards to like neuroprotection, hasn't it been proven already that particular types of exercises slow progression?
Excellent question. We actually had a full session on that recently at the Parkinson's Study Group meeting. And Dr. Bas Bloem, Blom, is the international lead and advocate for this. And I would say the jury is still out on that. There are unquestionably studies that have demonstrated some slowing of progression from exercise. But the reason why the jury is still out of that is because you cannot well develop a proper control and blinding for exercise-based clinical trials. And there is also a question about mechanism, because some people argue that part of the reason why people do better who exercise is because they are conditioning themselves. It is the musculoskeletal and even the nervous system conditioning is why they do better. Their scores would be better, etc. But it doesn't necessarily prove that you are neuroprotective. In other words, you are actually salvaging the neurons. In other words, there have not been done long enough so-called washout studies where you stop the exercise. And why would you stop the exercise anyway? You know, we don't want to hurt you. All the currently ongoing placebo-controlled trials for neuroprotection shouldn't compromise otherwise standard clinical treatment. So stopping exercise to me looks like not a good thing. But the bottom line is that in order to know whether you actually exerted a lasting change in the neurons, you would need to have a washout and then compare to a control group, and that hasn't happened. So it's promising. I'm certainly on the same board with Bass, and I am advocating the exercise. Whether or not you can consider it proven to be a disease modifying, I'm not completely sold on that, but I think that certainly is a possibility.
And as Nike would say, just do it. So,
Oh, absolutely. I'm very much in favor.
all right. Well, this has been a fascinating and very informative. I think we all knew that research was complex, but I don't know that we all had such a great inside view of what I was going into making these things happen, from theory to actually being something that we can utilize. So we thank you so much for giving us your
We are
time.
close. I want to close with saying that we have never been close to an actual breakthrough. I think it's in arm's reach.
Absolutely. Well, if everybody could give the wave of gratitude to Dr. Murray, we're so thankful that you joined us today. It was awesome. And we look forward to having you again. Thank you, everyone, and have a good rest of your Monday. Thank
Thank you,
you.
everyone. Thank you. Bye bye.
Bye-bye.